So we now move to the other side of the pond, and David Adams is going to give us a reflection of what is happening in the United States of America, with a fairly free rein to talk about whatever he wants.
Yeah, he gave me clean rein, and I decided what I would do is show you some data that you probably haven't seen unless you were in San Francisco last November, and that's about the current sort of status of the CoreValve. I think everyone here knows the partner, three partners papers now, and I'm just going to give you a little bit of information about where we stand currently with the CoreValve project. Of course, by disclosure, I'm the surgical national principal investigator of that trial, so obviously I have a bias toward the data, and also wanted to share it with you. So this was the CoreValve pivotal trial. We have an extreme risk arm and a high risk arm. It's a little bit different than the partners trial in the sense that the extreme risk arm obviously came after the partners B trial. So we needed to have we couldn't really randomize patients anymore for extreme risk. The CoreValve device, as you know, is a nitinol sheath. It can put it through an 18 French. It's got a tri-leaflet porcine prosthesis. And when we negotiated that side of the trial, we also wanted to address this transapical population identified in partners. But of course, we weren't going transapical. We were going to go retrograde with a non-iliofemoral approach, either subclavian or direct aortic. So that was just a side part of the trial, and I'll show you both these arms of the trial. And that publication actually is going to come out in JACC during the American College of Cardiology. Now, the high-risk arm of the trial was a randomized trial between the CoreValve device and surgery. Increased risk was assessed both by STS-PROM, and in addition, we were much more, I think, inclusive of additional potential risk factors not covered in the STS predicted risk of mortality models, such as porcelain aorta or liver disease, or there were our frailty, our independent living. So there were a lot of other things that surgeons could argue to get in that trial. That's almost an 800 patient randomized trial, and I'm going to be presenting that at the American College of Cardiology during the late breakers. So that I can't talk about today, but that information will be out in the next 3 or 4 weeks. So the study purpose of this one was to look for our extreme risk was, like partners, to look at patients that had a chance of mortality or irreversible morbidity of 50%. At 30 days, the risk again was determined for extreme risk by a local heart team, and then it came to a national screening committee, which had 2 cardiac surgeons on it, and that's how you got into the trial. The primary endpoint was all-cause mortality or stroke at 1 year. You had to have clinically significant and accurately defined aortic stenosis to get in. You had to have some symptoms, and the majority of these patients were symptomatic, were significantly symptomatic given their risk. There were the usual sort of exclusion criteria to look at. The screening committee was chaired by Mike Reardon. That actually was really, I think, important. There were 2 weekly phone calls that were about 2 hours each. On the phone, we would get an electronic version of the patient's STS, not just the risk, but all of the factors that went into that score. We would also get the core lab adjudicated echo, CT, and then the route of access would be decided all on this national call with each patient. So about 20 pages of information were reviewed on each patient to get in the trial and then actually have your route access assigned. And that was the conduct. I must say that was incredibly, there was a lot of scrutiny per patient for that. We needed a performance goal because it really ethically couldn't randomize patients anymore to medical therapy based on the Partners B data. So we calculated that based on contemporary balloon series, which was allowed in the medical therapy arm of Partners B and the Partners trial, and came up with a goal of 43%. So that was sort of going to be our target, which we would measure against the TAVR. There were a number of centers, actually, I think, again, a little different than the Partners trial, we had many more centers, 45 at the end, 40 centers in this, 45 in the high-risk trial. And also different than partners, we had about triple the number of centers that enrolled more than 10 patients. So we had a much more active participation in terms of centers. I think maybe even more of a reflection of of real world, not quite real world, but it was more, I think, more real world, where partners had much less centers that contributed relatively more patients. Here's the distribution of how the cases got out. You can see the screening committee that it had approved a total of 737. There were various dropouts. Most of the data I'll show you is as treated. We also looked at the ITT population, obviously, but per protocol, we were looking at an as-treated population. And we'll start with the iliofemoral group of 471 patients. The study compliance was really excellent, as you would expect in a prospective, well-funded trial. The patients were old. They were very sick. We probably were too tough at the beginning. Over the course of a 2-year trial, you learn a little bit about type C patients and who shouldn't have this. We probably took too many risky patients to begin with, and we pushed a lot of patients toward high risk. The average age was 83, typical population of what you see here. The average age was 83. A lot of lung disease was probably the most common marker inside the STS database. Very elderly patients. We took a lot of time to look at frailty factors such as assisted living, CAT score, dementia, and actually things like whether you were wheelchair bound or not, and actually whether you were toilet dependent or not. So there were a lot of factors that we looked at in secondary analyses that were just an extension of partners, meaning we had much more, based on their information, we collected a lot more data trying to define type C patients. So this was the primary endpoint, the outcome. Again, the performance goal was 43% would have been sort of the maximum. We had to be under that. We actually came out for an all-cause mortality or a major stroke rate of 25.5, which was highly significant and really, I think, showed a positive trial. This was the all-cause mortality versus cardiovascular mortality. At 1 year, again, and not doing a comparative trial between partners because this isn't a comparative trial, but the numbers are certainly similar. Here are some of the secondary endpoints. Stroke rate was low, actually lower than the partners trial. The bleeding rate was high, and we went by VARC definitions for all of these things. The permanent pacemaker rate was around 20%, which was lower than a lot of single series and other registries. We paid a lot of attention to dilatation and depth placement during the course of this trial. As I told you, the stroke rate was actually very low, probably reflecting it's a lower profile device than the original SAPIEN that was used in the partners trial. As expected, survivors saw a significant improvement in their New York Heart class. If you looked at KCC or various other quality of the two different sort of quality of life perspectives, survivors did much better than baseline after relief of their aortic stenosis. Not surprisingly, the device obviously is very effective, frankly more effective than, I think I'll leave it at that. It's very effective in terms of relieving aortic stenosis, and we certainly know from the published literature so far actually more effective than most surgical prostheses. Our paravalvular regurgitation rates were actually low. They are lower than what has been reported in some of the later partners trials. And importantly, and again, that's important. This trial, like every trial, has shown that there is a mortality associated particularly with severe MR. Now, interestingly, in our data versus Cadale's sort of 2-year follow-up in partners, we haven't seen the same impact of moderate MR or moderate AR on survival as has been reported in some of the partners' data. But clearly, you want to try and avoid residual regurgitation. Now, this was something that was interesting that we looked at carefully, and that was that a lot of patients that survived during the trial saw a diminution of their regurgitation over the course of the trial. Probably some of that's related to healing and of the device. Some of it may have reflected the nitinol and maybe some continued remodel or expansion, but that was something that was pretty evident in a very careful sort of patient-by-patient analysis over the course of the trial. Here are some of the other secondary endpoints, and then we looked at various predictors of mortality. Nothing really stands out there other than very sick patients with very high STS do more poorly. And then here are some of the other risks for mortality or major stroke that you would expect based on our surgical experience that was also consistent with TAVI. We have a much larger experience in continued access, almost 1,200 additional patients, including 800 that were treated with the iliofemoral, and these things have continued to show stable results over this much larger experience after enrollment completed. There you can see the all-cause mortality and major stroke rate actually decreased a little bit in continued access versus the pivotal trial. So, of course, we concluded that in this trial that it was obviously a very positive outcome in terms of not only just compared to the partners' data, but more importantly, this pre-specified performance goal. We saw actually lower rates of stroke that had been reported in a lot of the literature, and a low rate of aortic regurgitation that also changed over time. And our outcomes were stable and actually improved a little bit in continued access. So that was obviously a very positive trial. Now, the other arm of that I showed you were these patients that do not have access for iliofemoral. This was just a registry. It was not randomized. There was no performance goal defined. This was really a sort of a first-in-man prospective look at what happens with non-apical, non-iliofemoral TAVI. And so these patients had a combination of direct aortic and subclavian. We started out with subclavian, and then most centers went toward direct aortic. So we were going to be allowed by the FDA to do 200 subjects, and I'll show you the data on 146 patients that came in. And there's that how we got to that. And then again, we have another larger series of continued access patients that were treated with non-iliofemoral access routes. So these patients are more morbid. When we looked at sort of 67 variables, I show you the ones that were different. There was obviously more peripheral vascular disease, more lung disease with more severe sort of lung disease. And here's the difference between pivotal and continued access for those patients. Again, you can see in continued access, we got a little more clever about these Class C patients. So over the course, long term of the trial, we started to be able to pay a little bit more attention to deficits as well as to severity of lung disease. Here was the procedural summary. And again, I think the important thing is to show that over time, we move more toward direct aortic approaches from subclavian approaches. And actually, these procedures were very efficient. The mean time was still around an hour to do these operations. Here's the all-cause mortality or major stroke rate at 1 year for this population, which was obviously higher than for the iliofemoral group, not too dissimilar from, actually very similar to what you see in the partners data if you break out apical versus iliofemoral. So not to be expected, patients with severe peripheral vascular disease have a more of an issue. And again, there was no performance goal, so you can just say that's an observation, 41%. And then here is the difference between the pivotal and the CAS. Again, the mortality or major stroke rate decreased a little bit over time, as did primarily on the basis of stroke. A little bit difference in mortality. Again, I think we were selecting patients more carefully and continued access, and the other parameters stayed around the same. And then this is again, comparing just for reference point, iliofemoral, non-iliofemoral, pivotal, and the non-iliofemoral CAS. And you can see the vascular complications continued to sort of get better as we sort of direct aortic, in fact, sort of paradoxically, because you're not blind, open techniques tend to have less vascular complications. The patients did very well with non-iliofemoral, same sort of story in terms of heart failure, valve hemodynamics. Paravalvular regurgitation, again, was very low. Quality of life again, improved significantly in patients that were treated with non-iliofemoral. And here's one slide I will show you some comparison with partners. This is the CoreValve for non-iliofemoral and iliofemoral, and then this was the Partners B medical therapy 50.7. So again, even in the higher risk arm, I think we were pretty confident that we got reasonable outcomes. So the non-iliofemoral cohort was at higher risk versus our iliofemoral patients. Direct aortic access or subclavian non-iliofemoral approaches were reasonable, and it appeared to be a like transapical approaches associated with a little bit increased risk for patients, but certainly a viable option for patients that aren't surgical candidates. And this is sort of where we are today. The FDA approved the CoreValve device for extreme risk patients for both iliofemoral and non-iliofemoral without a panel in January of 2014. That is unprecedented in the United States for a device to be approved, a cardiovascular device to be approved without an expert panel sort of review of the data. And basically what that meant was the FDA didn't require any expertise to sort of assess the positivity of the trial. And as I mentioned at the beginning, the final results of the high-risk randomized trial are going to be presented at the ACC in a few weeks. Thank you for your attention.
David, thank you very much. Just whilst there's some questions coming, as well as the data, the rollout of TAVI in Europe was less structured in the US. And, I think that in some units there are some turf wars between cardiology and cardiac surgeons. I mean, can you just give the audience a flavor of how this worked in the US and the way it panned out?
Sure. Well, I can tell you from the CoreValve perspective, all these, only, I guess, 4 centers out of those 45 or 5 centers did not have cardiac surgeons as one of the PIs. So we've really made an emphasis on cardiac surgery being involved in these procedures. So 95% of these devices were put in with cardiac surgeons as part of the implanting team. So rarely did that not happen that way. And that's continued, and that's been our policy, or Medtronic's policy, in the beginning phases now of the rollout, which obviously we're still very early into, but that is certainly something that we're emphasizing. So in our center, cardiac surgeons have been involved in every TAVI procedure, regardless of the access route and regardless of the device. Obviously, we use the SAPIEN device as well, but I don't know what happens here, but that's been certainly been, I think that is the most common thing that's happened in the United States. And it's interesting because when CoreValve came to Europe, as you know, there were no surgical involvement. And when I got involved, it's when CoreValve went to the FDA and basically was told, we will not, let this trial move forward in the U.S. without cardiac surgical involvement. And that's actually, before Medtronic was involved, there already was a strong sense from Julie Swain, I think, was really directing that this needed to be an interdisciplinary trial as opposed to just a cardiology run trial.
Well, I think it's an important message because I don't think there's any doubt that TAVI is going to become a significant part of our armamentarium to treat patients with aortic valve disease, and unless the surgeons are around the table. And I think one of the key things that you said, that's with with femoral implants as well. We shouldn't have this division of surgeons doing transapical and direct aortic and cardiologists doing transfemoral. I really don't think that's the way forward.
And CMS, fortunately for us, that's all come down to Mike Mack gets the credit for that. Mike Mack working with Holmes at ACC basically put that in writing, saying that the reimbursement is going to be 20% higher and split evenly between surgeon and cardiology. So follow the money. It's always about that at the end of the day. In the United States, you really, the reimbursements is to get the maximum reimbursement for the hospital, a surgeon and a cardiologist have to work together.
Olaf, do you have any comment on this experience to the registry guy?
I think it's great data. I think it was awaited for a long time, and I think it's good that there's a second device in the US. I think for a lot of reasons that is good as well. I mean, when one looks at the outcomes, and interpretation is obviously quite difficult with the groups being so different, but one of the biggest differences is that is still the pacemaker implantation rate. Do you think, from your point as a surgeon, does it make a difference that you have a pacemaker or not?
Well, we haven't seen any difference in the cohorts that I showed you today. We haven't obviously seen any difference in mortality associated with the implantation of a new pacemaker in these patients compared to those that didn't. Now, that doesn't mean that's still, first of all, still a 1-year follow-up, and two, that we don't know about younger patients that would live longer. But I think there's a trade-off, and I don't know that we'll ever know the real balance of that. The stroke rates were lower in this trial than with the SAPIEN. The pacemaker rate's higher, and the paravalvular regurgitation is lower. So maybe nitinol and the size of it gives you, and maybe something to do with the catheter, gives you a lower stroke rate, less bleeding, and less paravalvular regurgitation at the expense of a sick 5-fold increase in the pacemaker usage. That might be a good trade-off, actually. So I don't think you can ask that question independent of the totality of the strengths or weaknesses of particular devices. But so far, our data analysis does not show that impacts survival or quality of life.
I think it's interesting to have good data coming out with CoreValve, and I think the European registries would tend to suggest that clinical outcomes are very little different between these two devices, but there probably are different risk or complications between the two, which as time goes on, I do think we need to start looking at patients and perhaps having some degree of patient selection as to who might benefit from one device or the other.
Absolutely. I think we're early in that, figuring out who's, we certainly don't pretend to know yet what some of the nuances about which device for which patient, like we do for rings, say in mitral valve repair, where we're very specific at this point of our experience about why we would choose one prosthesis over another one. I'm sure that's going to come with experience.
Hi, I just wanted to ask, your paravalvular regurgitation rates are clinically significant rates, were a lot better than I know the UK and the French registries. I just wondered whether there was any particular explanation for that in your cohort that you kind of identify.
I think that the specifically is probably the CT sizing. So, every patient gets a CT that then was core lab reviewed, and there was a discussion about sizing. So, there's a lot more. I was at a European program a year ago and saw a patient that we didn't have any information on live surgery, and then they do a transthoracic echo, and just based on that echo, right then and there, we're going to use this device, and then the device popped out. And or you could have severe AI, whatever. So there's a big difference when you're doing, CT angiography and then having a core lab measure perimeters, and then an experienced team is looking at it. And if you're between devices for this patient, we're going to pick that based on the calcium burden or the angulation of the aorta. So I think that that's a marker of just the, sort of intensity, I think, that went into the sort of individual patient outcome here. But the reality is we're seeing from some of this data, I didn't have time to really cover the rest of the US, but Mike Mack's paper is a good one to look at for the early experience. It just published in JAMA for the registry data for real world with the SAPIEN device, and it's pretty similar to the trials. So. Without all that scrutiny, people are getting pretty much what they got in the trials.
Yeah. But I think the rigorous nature of selecting the patients and CT planning, certainly I believe, and I think the evidence now is really robust that if you CT plan your patients, you will get better clinical outcomes.
Yeah, I think that's something that we need to move toward.
Sasha.
How have you seen TAVI impacting the numbers for isolated AVR overall? Have the numbers been affected by this newly approved devices, or is it too early to say?
I don't think it's too early to say. I think there's more. I think there's more aortic surgery being performed. There's more aortic replacement being performed in the United States. That's coming at the expense somewhat of surgery, particularly now with the sort of release of the device from trial restrictions, and there is some inclination to do more intervention. Although, frankly, I think that's calmed down a little bit because. At one point you were sort of bringing patients in a wheelchair. Again, in our trial, I think in the extreme risk trial, I think 6% of patients basically were in Pampers. Should we really have been done aortic valve replacement? And we said that when we were looking at the final data. I'm like, Jeff, my gosh, 6% of patients are in Pampers. What were we thinking? So, that's sort of calmed down a little bit, that euphoria, and certainly patients want it. I don't know what happens here, but 75-year-olds want it now.
Yeah.
Hi, I'm Sai Prasad from Edinburgh. Fantastic presentation. Excellent results. Given the choice between SAPIEN and Core, having had your experience, if you want to ideally choose patients and select appropriately, apart from the size beyond 29 millimeter, where do you think the CoreValve has advantages over SAPIEN?
So again, remember, we're not using, I don't know what SAPIEN they're on here, 3. We're still SAPIEN 2, our SAPIEN original design outside of trials in the US. So certainly, it's phenomenal. You really have to hand it to the partners group for getting the results they got with the first generation SAPIEN. The first time we started doing them in the hospital, it looked like, again, it's all cardiologist perspective. Like the third patient I came in, I'm like, what's going on? All they couldn't do is they're doing a cut down. I'm like, what are they cutting down on? They're cutting down on the iliac. I'm like, their bowels were up, the vascular surgeons were in there, and I'm like, but this is minimally invasive, right? Like this, it's not heart surgery. So I think that my perspective may be somewhat jaded by the size of the original SAPIEN device versus the new ones. I will say that, again, from the CoreValve perspective, they are a small profile. They are very simple the deployment sort of new gadgets are all really quite simple, but frankly, we have not seen any, I can't define for you a morbidity issue with one device versus another and why I would use one yet, other than the profile, because we don't have the smaller profile SAPIEN. I do think that our paravalvular leak rate could have something to do with the expansion of the device, and the stroke rate is lower. I think, again, these aren't comparative trials because they're not included exactly the same way, but our stroke rate has been very low, and that may have something to do with not only the size of the device, but potentially how it moves around the arch, till proven otherwise.
Just one more, because we'll have to move on.
I would say it's maybe a question which is not possible to be answered by a trial like the CoreValve trial or the partner trial in the past. But it's definitely a question which has to be answered by national registries, and from that point of view, I would say national registries have a responsibility to answer that question, because that is the group of clinicians which should be more independent. The problem is a little bit that over the recent years, although data is, in terms of patient numbers is available, everyone is very cautious in making any step forward in any direction, because of course it's a highly political problem, but I don't think that it will be acceptable to wait for these comparisons for much longer. And I think some of the comparisons are available, maybe not stated, but available in the data, and I think it's always important to then compare these kind of outcomes if they are compared, for example, with the partner trial, with what has come out of registry data, and I think then maybe one get a glimpse of what the real world is. But at the moment, I think everyone tries to avoid all these questions to answer.
Thank you. Well, I think we've got somebody who's maybe going to come and describe a trial that may give you the answer as to whether there may be differences between devices. So moving on from registries to randomized trials.